Hi, Dr. Millett.
Hi, how are you?
How are you?
Good. I don't know the format of this, so I caught the tail end of Dr. Chen's talk. I'm not sure if I just follow him then in the same Zoom meeting, or how does it go?
Yes, so you should have the ability to now, as co-host, share your screen. And then I will wait a couple more minutes for people to transition. It's like if we're walking down a hallway and coming in a room and changing rooms, and then I'll introduce you and we'll start.
So you're hosting essentially.
I am, yes.
Co-hosting.
Co-hosting, exactly. So it looks like we have quite a few people.
Yeah, I can share my screen whenever.
Yeah, whenever you're ready, because we'll make sure that's working before. Sometimes it takes a minute for it to transition over.
Yep.
Okay, there we go. Great. Welcome, everyone. We are very fortunate today to have Dr. Millett with us, and we're trying to keep these as on time as we can. So we'll have a few people floating in as we start here. But I'm Trish with SK Life Science, and I'm also a volunteer here with Epilepsy Awareness Day Expo and for past several years, this wonderful event. I wanted to give a warm welcome to Dr. David Millett, who is the director of the HOAG Epilepsy Program in Newport Beach, California. That the HOAG Epilepsy Program is a comprehensive state-of-the-art level 4 epilepsy program. And Dr. Millett and his team do focus on patients gaining seizure freedom through the drug treatments and surgical options they offer. And Dr. Millett will be speaking today on understanding your EEG. So just a little sidebar as well, feel free to type your questions into the chat box and we'll make sure we get to them before the end of the hour. And we'll also have an open Q&A session where you can come off mute and get your questions answered as well. So Dr. Millett, it's all yours.
Thank you, Trish. Just to echo what Trish said, I have probably half an hour, 40 minutes of material. So it'll either be a really quiet end of my talk or people will have some questions. But usually this is this kind of a talk results in a number of questions or concerns that patients have, because most of the folks that are listening in today have either had EEGs or have loved ones or family members that have had EEGs and have questions about it. So this is a talk I've given, I think, every expo for the last 5 or 6 years. And typically it's in person, and typically there's a big board and I, with dry erase markers or pens, and I kind of fill things up. So this gave me the opportunity to put some of it down, I guess, in a PowerPoint. The talk is on understanding your EEG, and I'll kind of to back up a little bit. So I think some of the talk will just be on understanding EEG. What is it? Not just understanding your own EEG, because obviously, you know, there are all some similarities between them. And I'm going to kind of touch on all of the items that are listed on the right side of this this title page. Briefly, kind of give people an introduction to EEG, both in terms of what the term means, the history of it, what it looks like today, how it's recorded, who reads it, some terminology issues. I'll try to give people a sense of what it is that we are looking at, how we're thinking about EEG, assuming that whoever's reading your EEG is actually thinking about it. And then we'll get in, I'll just show you some examples of some normal EEGs and a number of abnormal EEGs, and then we'll kind of open it up for questions at that point in time. So without further ado, what is an EEG? EEG is abbreviation for electroencephalogram, which from the Latin literally means the written electricity of the brain. And what we now know as the EEG and what we practice every day was developed in the around 1930 by a German neuropsychiatrist by the name of Hans Berger. I've written a little bit actually about Berger. My doctoral dissertation is on the history of cerebral physiology, and so I've been to Jena where his laboratory was and gone through his diaries, and he's a very interesting character. He believed in psychic energy and mental telepathy, and the discovery of the EEG was actually a kind of an offshoot of his own interest in trying to determine how the energetics or the thermodynamics of thought. And as you can see, Berger in his teaching in the lecture hall in Jena in the mid 1920s, and his the first setup using what was called a string galvanometer at the time, that he was able to record the EEG. And the first tracings that you see here at the bottom of the screen were of his own son Klaus. And so EEG that we know today is obviously a technologically sophisticated test that relies on a number of electrodes fixed to the surface of the head. The folks in the background here will be familiar faces to most of you who've been to the event before. But EEGs goes far beyond today surface electrodes of the brain, but also grids and strips that are affixed directly onto the surface of the brain for seizure mapping at the time of surgery. And most recently, the trend has been towards what we refer to as stereotactically placed depth electrodes. And at the bottom of the screen, you can see an X-ray of a skull that has about 18 very, very thin depth electrodes implanted in a number of different areas of the brain, trying to identify exactly where seizures begin and how they spread. So all of these things fall under the kind of the heading of EEG, has a very rich history and means a lot of different things today to different people. So we could talk a little bit about electrode application. Most often the EEG is obtained by applying these disc or cup electrodes to the surface of the scalp according to a system of reference called the 1020 system that's been around since 1956. And it divides the head into different angles, and you can measure or mark off the location that the electrodes should be applied. And it's the same process of applying electrodes for every patient. If you're using this type of setup, which is basically the individual electrodes and wires, EEG technicians have to learn this process in their training programs, and they have to demonstrate that they can skillfully apply that technique before they can be certified or registered. Talk a little bit, just some other pictures. So this was the first apparatus that was used to record EEG back in the United States back in 1937. EEGs back then were written out on scrolls initially. They were 3 channels or 3 squiggles across the page, and scrolls could be rolled or unrolled and reviewed. As you can see, Fred and Erna Gibbs and Bill Lennox at Boston City Hospital, Boston Children's Hospital in 1938. So this test has been around for quite a long time. Initial amplifiers took up 5 racks of vacuum tube amplifiers in very large laboratories to obtain even a simple EEG of a subject. And now they're miniaturized. They can actually be miniaturized and worn on top of the head, or miniaturized and placed in a backpack or carry-all. So we've had tremendous advances in the miniaturization of the electronics. Similarly, there have been some developments in some of the application of the electrodes. Here you see a cap that is often used in clinical practice, where you have different sizes of the cap for both adults and children and infants. And then the electrodes are actually kind of manufactured and incorporated into the design of the cap, and you basically lift up each one of those these individual electrode caps and fill it with gel to create an electrical conduction in order to record the EEG. And finally, we have now very complicated sets of electrodes for largely for research purposes, but sometimes they can be used clinically as well, up to 250 electrodes over the face and the head to more precisely localize exactly where seizure abnormalities or epileptiform abnormalities are coming from. So we have a variety of different apparatuses for both recording and then amplifying and analyzing modern EEG. We'll talk a little bit about the duration of EEG, which is quite important. Most EEGs, I think, still performed in the outpatient setting and also in the hospital, in the emergency rooms and up on the floors. If you were to order a routine EEG or a stat EEG, that's typically a 20-minute study. In that 20 minutes, oftentimes patients are awake for the majority of it, unless they're being hospitalized for another reason. Perhaps they've just had a seizure and they're in that postictal phase where they're very sleepy or obtunded. But most oftentimes, the routine EEG that when patients come in with an EEG report, it's a 20-minute study that's been performed in somebody's office or in a hospital, and the patient is largely awake throughout it. That's important to keep in mind, because the most provocative state that one can capture an EEG in is the sleep state. Sleep tends to bring out abnormalities, and a lot of sources of artifact that can interfere with the interpretation of EEG tend to die down during sleep. So it's very important actually to capture a significant period of sleep during an EEG in order to determine whether it's normal or abnormal. And hence we move from the routine 20-minute study to the extended EEG, which can be either 45 minutes in duration or an hour. And from there to the ambulatory study, which is typically at least an overnight 24-hour study performed in the home setting, can be performed up to 72 hours in duration without significant breakdown in the signal quality over the course of that time. From there, we have what we refer to as long-term EEG. This tends to be multiple days on end, performed in an inpatient setting, typically in an epilepsy monitoring unit, but sometimes on the general medical floor or in the intensive care unit. So this would be for example, for what we call differential diagnosis, to determine whether spells that patients may be having are epileptic or non-epileptic in their underlying cause, or for surgical evaluation to determine whether patients would be a candidate for resection, for laser surgery, for an implanted device to help control their seizures. And then finally, we actually have now chronic or implanted devices that record EEG. one of the newer devices that we are often implanting these days is called RNS, for responsive neurostimulation, and this is a device that continuously records EEG or brainwave activity, and when it detects the electrical onset of a seizure, delivers a current to abort or to terminate that seizure. So we actually have data now that we can read from patients that are walking around with these devices, and the devices are actually storing little bits of EEG throughout the day, or if it detects a seizure, we'll store that bit of data, and we can actually, from our office or from our home where we might have a secure internet connection, we're able to log on and actually review EEG in patients who are walking around and have these devices in their head. I've already sort of mentioned the different environments that the EEG can be obtained in, so I'm not going to spend too much time on that. Who reads it? I can tell you that the person who interprets the EEG is probably the second to the duration of EEG, the most important factor in getting a high quality EEG. I should note that there's a difference between what I do and what most trained electroencephalographers will do, which is basically read an entire study. We'll actually visualize 24 hours of data, or 48 hours, or 45 minutes, however long that EEG is. We'll actually visualize the entire study, oftentimes reading at pretty high velocity. We'll be reading, in a period of maybe 2 or 3 minutes. I can process probably an hour or two worth of data. That's quite different from what many of the larger companies have done in the past, in which little bits and pieces of EEG over the course of a day or 24 or 48 hours are audited and then compiled into a file, or the EEG is screened by a technologist and then sent to a physician to sign off on. That's a different kind of level of quality in terms of how much of that EEG is actually being interpreted. We now have machine learning and algorithms that can detect spikes and seizures. Sometimes they're accurate, sometimes they're not. That whole process really needs to be overseen by somebody who has experience reading EEG. There are no formal requirements, so we have well-trained clinical psychologists that issue EEG reports. We have general neurologists that have had no background in neurophysiology, EEG, or epilepsy, who will read EEGs and issue reports. And then we have trained epileptologists or electroencephalographers. Typically, now they have completed at least 1 year of training in order to finish their their fellowship. I completed 2 years of training, and up until about 7 or 8 years ago, all of the EEG and epilepsy fellowships were 2 years of training after neurology residency. So, in those periods of time, we would read somewhere between 400 and 700 EEGs per year under the supervision of an expert electroencephalographer or epilepsy specialist before we would graduate from that fellowship program and be permitted to read EEGs on our own. So I'm going to spend a few minutes talking about terminology, so you can better understand kind of these a lot of the funky words that you might see in an EEG report. So here we're now moving into understanding your EEG and your EEG report. So first, a few words about bands or frequency bandwidths. We typically see on a a routine EEG or a scalp EEG, four major bandwidths, and the large box with the squiggles on the left side highlights those four, and they go from the slowest waveforms, which are delta waves here in the top, and this is anything less than 4 cycles or 4 cycles per second, or 4 hertz, down to theta, which is between 4 and 7 hertz or so, and then alpha, which is 7 to 12 hertz, and beta, which is anything that's over 12 hertz. So we go from the slowest to the fastest activity that is typically depicted in a scalp EEG. There are waveforms that are faster than beta, typically referred to as gamma, but they tend to get filtered out from being recorded at the scalp by the bone and the soft tissues of the head. So these are the 4 bandwidths that we typically see. And again, I mean, these boxes are a little bit wide, so this is 1 second in duration, which, as you can see on the right with some of these examples on the right side here, each second is indicated by one of these solid green lines. And that'll be a common theme for some of the examples that I illustrate with the rest of the talk. So every time you see a solid green line coming down the page, that's a 1 second marker. So what you see, for example, here is a mixture of probably 7 or 8 hertz activity here, some faster activity, maybe in the 12 to 13 or 14 hertz here, but also some slower waves, probably in the theta range of about 7 hertz, and up here above, some slower delta waves. So these are the different bandwidths that we tend to discuss when we talk about mixed theta and delta as being the background. That's generally speaking activity in the 4 to 7 or 8 hertz that's typically intermixed together, and I'll show you some examples of that. Montages is another term that you might see, and refers to essentially the way in which all of those electrodes over the surface of the head are connected up to one another in order to render a channel of electrical activity that we can see. And the lower corner here of this slide, you see. Hang on, let me move my little zoom marker is right in the way. So what you see here is an illustration of 2 different types of montages that we typically use. One is called a bipolar montage, where we actually connect in a chain a series of adjacent electrodes, and we essentially subtract the electrical activity that's recorded at this electrode, for example, from the electrical activity recorded at this electrode. This is all done through the computer now, and the difference between these 2 channels in their input then creates a voltage, and that voltage is then depicted over time in this EEG illustration here. Similarly, this channel and this channel could be subtracted from one another to create this channel here. This electrode and this electrode, the activity would be subtracted to generate this channel here. So basically, these 3 channels, this 1, 2nd, and 3rd channel here, march out the electrical activity over the right side of this cartoon's head, basically from the front to the back. And I'm going to show you some illustrations of that, some more real-life illustrations in the next page. This bipolar montage is quite different from what we call a referential montage, where each of these points over the surface of the head are independently measured against some reference. That reference could be a variety of different things. Oftentimes it's what we call an average reference, where all electrodes over the surface of the head, the electrical activity of all those points of contact are averaged to create one value that changes over time, and then the electrical value, the electrical activity, I should say, at each of these contacts is used, is then the average is subtracted from this value to create the voltage that's then represented in the graph. So as you can see, these are two complementary ways of, or montages, different ways of illustrating the electrical activity, and they can be useful in different situations depending on the size of the abnormality and how it electrically projects to the surface of the head. I'll talk a little bit just about now some of the abnormalities that we use this term epileptiform. Epileptiform refers to an abnormality in the EEG that we think is likely to be related to an underlying focus of irritability or tendency to hyper-excitability of the brain. Those are often areas of the brain that give rise to seizures. And so you'll see this term epileptiform used to describe different patterns, often transients. By transients, I mean it's just a brief pattern that exists for a second or a fraction of a second. It comes out of the background and then it goes away again. And these, what you see here in the upper right-hand panel, are good examples of epileptiform discharges. In the middle, you see the classic epileptiform discharge of a spike wave or spike and slow wave complex. That's this 1, 2, and 3. These are 3 separate discharges or complexes. We see the spike here and the aftergoing slow wave. The spike is defined as anything that's less than 70 milliseconds in duration, whereas a sharp wave you can think of as basically being a spike that's been pulled apart a little bit. So you see this spike again. This one's probably about 50 milliseconds in duration. But if you pull this spike wave apart, you basically end up with a sharp wave complex that looks like this. So sharp wave complex is anything greater than 70 milliseconds in duration and less than 200. So the sharp part has to be less than 1/5 of a second, but more than 1/10 of a second, essentially. And so these are fairly typical examples of epileptiform discharges that can occur either over one particular area of the brain that tends to be hyperexcitable, might give rise to seizures, or it can be a more generalized pattern. And we'll get into some examples of those. I just want to make sure I'm not going, that I'm getting not too far behind. I'm going to get far behind because I like to talk. Just a moment about artifacts. About 70% of learning to read EEG is actually learning to identify and ignore artifacts. Everything causes artifacts. Eye movements, eye blinks cause artifacts. Deep respirations can cause artifact. Any kind of muscle activity over the head, the scalp, the neck, or the face can cause muscle artifacts. The electrode has to make a very close connection with the conducting gel to the surface of the head. If that connection, if an air bubble gets into that between the electrode and the head, or if that electrode becomes loose in any way, you can develop artifact related to the electrode itself. And then all kinds of environments, cell phones, iPads, laptops, noisy electrical environments. If you're anywhere near any large device that creates electrical or strong magnetic fields or pulses, it can cause an artifact in the EEG. EEGs in an ICU are very challenging to read sometimes because there's just so much equipment going on. There's drips, IV pumps, all kinds of things. So we have to recognize that artifact is a part of every EEG, and we have to just learn to sort of read through it to try to pick out the underlying brain abnormalities. So I talked on the last page a little bit about montages. I think hopefully this page, if that was confusing to you, will give people a better example of what I mean by montages. The cool thing, there are lots of cool things about EEG. One of the coolest things about EEG is that we're basically taking a three-dimensional structure, this hemisphere from the top of my ears to the top of my head is essentially a half dome. It's a hemisphere. We're taking that surface in 3 dimensions and projecting it on the page in 2 dimensions. And in order to do that, we have to sort of unfold things a little bit. And montages are the way in which we do that. What I've shown here is what's called the standard 1020 system. This is an international system for placement of the electrodes over the surface of the head. And then this montage, this is my favorite montage. Most of the folks that sort of went through similar training programs as I did have a very similar montage that they use. This is the way in which these individual contacts over the surface of the head get connected up to create a pattern on the page. And when we see these patterns on the page, they're not just squiggles, they represent different parts of the head. So what you can see here, and I'll show you in a series of animations briefly, what you see down below is that these different electrodes are connected up with different colors. And over here you see on the left side of the head, the most anterior or the frontopolar electrode connected to the anterior temporal or frontotemporal, to the mid-temporal, to the posterior temporal, to the occipital. If you look at the EEG tracing in the middle of the page, what you see is this red bar is a reflection of these 4 channels of electrical activity that is derived from these 5 points of contact over the surface of the head. If you go to the other side of the brain, to the right side, you'll start here at the right frontal pole to the, hang on, my mouse disappeared, to the right frontotemporal, mid-temporal, posterior temporal, occipital, and here in this purple bar, this is the representation of electrical activity over this temporal lobe. If we go down to the next set of 4 squiggles, we see the electrical activity that starts here over the left side of the left temple and moves across the head over the vertex, over the top of the head to the right. So these 4 channels basically show the electrical activity left to right over the top of the head. And finally, the last 2 panels of green and blue, as I've illustrated here, show us the electrical activity as it's recorded over the left side, just to the left of the midline, what we call the parasagittal. Sagittal is midline, and parasagittal is just to the left. Parasagittal is just to the left of midline, and right parasagittal is just to the right of midline. So when we are reading an EEG, not all squiggles are created equally, and the squiggles actually reflect the electrical activity in a topographic arrangement that corresponds to different parts of the head. Having them arranged in this way allows us to compare, for example, the electrical activity of the left temporal lobe to the right temporal lobe. If we see something here that's not here, we know it's coming from the left temporal lobe, and vice versa, or conversely for other parts of the brain. Hopefully that sort of clarifies some of the confusion about seeing these pages full of squiggles and all these letters and numbers and what do they mean. So let me talk a little bit about normal EEG. There are entire textbooks dedicated to EEG of the newborn, EEG of the infant, EEG of the toddler and small child, and EEG of the adult. Generally speaking, over early development, from the newborn period, and actually even EEGs of premature infants, there is a maturation pattern that's a normal pattern of maturation from about 22 weeks gestation to 40 weeks to the time of normal delivery. And then another maturation pattern basically that occurs from birth essentially through adolescence. By the time patients get to the age of 12 or 13, more or less you have a mature EEG with what's called a posterior dominant rhythm, or PDR is the typical abbreviation. So that's normal oscillating rhythmic activity over the back of the head. That's where the posterior comes from, that occurs in a restful state. And I'll show you an example of that. As you can see, that pattern begins much slower, about 5 hertz by the end of the first year of life, often mixed with these slower theta and delta waveforms. By the age of 3 years, it often matures from 5 hertz to 8 hertz, and then settles down over time at the 9 to 10 hertz, which is essentially the mature or adult background during the awake state. Sleep is a very different state of EEG, and there's a lot of architecture that's quite different in sleep states compared to awake states. I'll show you a few examples of things like vertex sharp waves, what we call sleep spindles, and K complex. These are quite different. We don't see any of this activity during the awake state. They're very much specific to the sleep state. And we don't often do this with EEGs, but if any of you have had a formal sleep study referred to as a polysomnogram, they will actually designate this period of time as N1, N2, N3, and REM sleep. That's a histogram of your phases, different phases of sleep. There are a lot of normal variants. That is to say, there are lots of different ways that a normal EEG can look abnormal. This is where that dedicated EEG and epilepsy fellowship training really comes in handy, because I've seen many reports that have come to me from less experienced readers who are describing things, and I just think to myself, that doesn't sound right. Bring me that EEG, and I look at the EEG, and it's actually just a normal variant that looks sharp. It looks like an epileptiform discharge, but based on where it is and when it appears in the course of awake and sleep, it's actually just a normal variant. And so it's really important to keep the presence of normal variants in mind. Just going to show you some EEGs now, and then we can kind of open it up to questions. Probably spend about 10 minutes going through a bunch of EEGs. This is what a normal posterior dominant rhythm looks like in a young child. As I mentioned before, the green lines are 1-second markers, and what we see here is about an 8 to 9 hertz rhythmic activity over the back of the head, best seen in the left posterior and then the right posterior channels, both the ones coming across this way, the temporal chain, and then the ones coming over the head. So you see, as you can see them in these 4 channels. This one actually has a normal variant called posterior slow waves of youth. And if you can imagine that, for example, here, those faster waveforms, that alpha activity is riding or undulating on top of these slower waves. This is a very, very common normal variant called posterior slow waves of youth that we can see in this EEG. This is the pattern that we would often see in a child of perhaps 5 to 8 or 9. As that child then matures into adolescence and adulthood, we see essentially the same frequency of the background activity. It's now a little bit reduced in its amplitude, but what's the striking feature is that that all of that other slow activity has flattened out. This is a low voltage or low amplitude awake background with a normal posterior dominant rhythm. So just going back again, you can see once again, a lot of this slower theta and delta activity is now gone once a child gets into the adolescent period and adulthood. Here's an illustration of some of that sleep architecture that I mentioned. K-complex. A K-complex is a polymorphic. It has multiple phases. This is one K-complex in the middle of the screen. And as you can see, it deviates initially in this channel negatively, then positively, then back negatively again. You typically